Atherosclerotic disease is one of the major causes of death all over the world, also in the United States and Europe. And DAPT, as dual-antiplatelet therapy, is a mainstay of the treatment of coronary artery disease after stent implantation. So there is currently a divergence in international guidelines on what should be the correct dual-antiplatelet therapy duration according to clinical presentation, with American guidelines that suggest a standard duration of 12 months irrespective of the clinical presentation, and European guidelines that make a differentiation 6 months to stable patient and 12 months to not stable patient. So our research question was to dig a bit deeper in this matter of controversy, to see if from a previous prospective trial that we conducted, the PRODIGY trial, we could have some more insight on this topic. So our findings were, we did not observe any difference as the efficacy on the ischemic endpoints in both ACS and stable coronary artery disease patient after a prolonged dual-antiplatelet therapy. However, with respect to bleeding events, we observed a higher risk of bleeding, a relative higher risk of bleeding in stable patients. The difference was a 5-fold increase in bleeding after prolonged therapy in the stable patient as compared to a 2-fold increase in ACS patients. And there was a positive interaction. So the two hazard ratios were different between each other. And in addition, when we considered together bleeding and ischemic endpoints, we observed that patients with ACS were not harmed from a prolonged treatment. And on the other hand, patients presenting with stable coronary artery disease had an harm on this composite endpoint with respect to a prolonged treatment. I believe that there is a continuous chase towards a personalized treatment of therapy towards this kind of patients. And there is a current consensus that a dual-antiplatelet therapy after stenting should be tailored on the ischemic and bleeding risk of the single patient. So I think that a differentiation between the ACS patient and the stable coronary artery disease patient is important. Well, I think that the take-home message could be that the dual-antiplatelet therapy, as I said, should be tailored on the patients, on their bleeding risk, on their ischemic risk, on the economical issue of the patient, and on the compliance of the patient. So the physician, the treating physician, should gather all this information together to give the best practice tailored on the single patient. Well, we have to highlight the fact that this was a subgroup analysis of the prospective randomized trial. So by definition, these findings are only hypothesis generating. So larger scale randomized trial focusing on this problem should be conducted before suggesting a change in the practice of this physician.